Thank you very much, Simar, and thank you for giving me this topic and to be able to participate in the course. The topic that Simar has given me is complex retinal detachment, diabetic, and vasculitic. Now, let's talk about diabetic. Important before you take up the patient for surgery is good metabolic control. Pre-op anti-VEGF agents may be given because they do reduce intraoperative bleeding, but be sure that the patient has all the clearances before you inject in anticipation of surgery. Pre-op PRP is important in diabetic patients, and while doing PRP, maintain a safe distance from the base of the fibrous membrane. Now, there are certain videos and tips that I would be showing for doing diabetic vitrectomy. I think the most important thing is to identify the right plane of dissections. Once you are in the right plane, the rest of the surgery becomes quite simple. Important to choose the cutter which allows you to work very close to retina. I mean, we do have up to 10,000, which may not be always required, but a good cutter is very important for diabetic vitrectomy. So to show you example of how anti-VEGF work and how you can actually resort to a single instrument vitrectomy without doing anything. Now, this is a patient with diabetic TRD. As usual, first you do core vitrectomy, making sure the entire vitreous which is in the core is clear, and then you identify the plane. The plane where your membranes or fibrovascular proliferation is away from the retina, and this is the plane from where you are able to enter, insinuate your cutter, and here you can see there is a node attachment. You are not seeing anything, but the proportional reflux is being used because that causes the egress of the fluid and makes the fibrovascular membrane separate from the retina or gets elevated from the retina, and then it becomes very easy to start cutting it, and you don't need, honestly, any other instrument to do it. So again, to show that how you would go slowly one by one, trying to separate the adhesions from the underlying retina, insinuating, cutting it, dividing it into different segments, and finally moving to the periphery. Mostly in diabetics, this is again the proportional reflux, which is separating the peripheral vitreous from the retina, and you can go up. Unlike vasculitic TRDs, which I would be showing subsequently, the diabetic TRDs fortunately do not have much in the periphery. So this is the patient, the same patient before and after surgery. The third important point is that there can be intraoperative bleeding. So once there is blood in the intraoperative stage, it's very important to take care of then and there only. Because the problem again in diabetics is when there is a blood, they kind of tend to form fibrin. So if you are handling something else somewhere and you think you will come to this area later, by the time there will be huge clot with fibrin which will be glued onto the surface of retina, and you will have to spend time to separate it. Now you can see here, there is a bleeder, there was a bleeder here. So the endodiathermy should be done there and then. These cutters allow you to go very close to the retina, and you may not even have to use instruments or extrusions many a times to separate. And this is what the adhesion is. Like there is a fibrin gets mixed with it, and you may have to spend time to take care of that fibrin and remove it as a clot. So this is the second part, but even if the bleeding is not getting controlled, please go on to raising the pressure and doing. Third very important step is sometimes you feel you have done a very good vitrectomy and you have peeled everything, even as an experienced surgeon. Now this is a patient with combined retinal detachment, had a break somewhere here. Can you switch off these lights, please? Had a break somewhere here, and you can see This fibrous tissue is being removed, and you will see there is a break underlying here. So you think you are removing everything, and as you will see subsequently, I think I can move forward a bit. This is just the technique of segmentation. Then there is another area of proliferation, which again is taken care of separately by cutting it from the nodes. So once you have completed it, you feel probably you have removed everything and there is no hyaloid because you have tried to look for the hyaloid, you have tried to separate it. But never forget to inject triamcinolone, because as you see, that even after the complete dissection, there is still the whole lot of the schisis part of the hyaloid which is attached and which needs to be taken out. So vitreous schisis in diabetic retinopathy plays a major role. The fourth component is microscope integrated OCT may help to identify the nodes, may help to identify even the schisis cavities which you have. And this is just to show the video of a diabetic detachment. First is you have done the core vitrectomy, and this is the node where it is firmly adherent. You can use microscope to decide your plane, like where it is, cutter is going and how far is it away from the retina. OCT intraoperatively can guide you. Not only that, OCT can also help you to identify the vitreous schisis. And this is what I'm going to share because I think my time is running up. So if you do not want to, for whatever reasons, you can see here the splitting of the vitreous into the two, and you know that your cutter has to cut not only the superficial layer of the vitreous, but also the deeper layer of the vitreous because of the schisis. If you are not using OCT, safest bet is to use triamcinolone acetonide. Bimanual dissection, these days with the kind of the cutters and all we have, honestly bimanual resection is not needed many a times, but still there would be cases like this where you have to resort to bimanual resection, so don't hesitate. I generally use cutter a lot and proportional reflux a lot, so even for bimanual resection you can see here the cutter is being used to create the plane. And this is the proportional reflux, which is going to help separate the fibrous membrane from the underlying retina, and then you can start segmenting it into multiple quadrants and chopping off those quadrants. So patience is kind of required. Changing the direction of the cutter sometimes is important. For example, here you would see that I was trying to insinuate from here, but it's not comfortable to the surgeon, and my time is up, 1 more minute. So if it's not working in this direction, move to the other direction where you may be able to find a better plane like this, and you are able to go, you are able to cut it, you are able to segment it, and finally it works better for you than the previous one. So if you're not comfortable going in from one direction, just change the direction and move on. The last 1 minute I'm going to take to vasculitic TRDs. Now, unlike diabetics, they have very firm adhesion to the vitreous and in the periphery. So the posterior pole is easy, but the moment you reach the mid-periphery or the periphery, you will see, now here you can see, unlike diabetics, dissecting the posterior pole is quite easy. You can separate these membranes, but the problem arises when you reach this area. This is where they have very firm adhesions, and you will end up creating the iatrogenic breaks. But the fear of the break should not stop you from doing a good dissection. You still have to, here you can see, you may use forceps, but again, they are very firmly adherent, so you may end up with breaks, which at times you may have to support, but a good laser and good dissection, there is no, alternative to it. So I'll skip the last video, and I think only one word in conclusion is to patients. Go slow, manage the things as they come along, and try to do a good and thorough dissection for both the entities. Thank you so much.
Thank you so much, ma'am. I think you covered the topic very extensively. If I may just ask one thing, a lot of times the key to diabetic vitrectomy is that we avoid making a break when there is a TRD. But once we have a break, it starts getting very bullous and things go bad. How would you proceed once you know there is a break and fluid starts seeping under the retina?
By and large, the diabetics would always have the fluid under the retina because even if there is a tractional detachment, there is a subretinal fluid. Only thing when we are not creating a break is we are hoping the retina will settle down on its own once we have done. But when we create a break, which happens most of the times or quite a few times, then it's better to take your cutter on a suction mode close to the break or a flute needle and try to aspirate the fluid. Once you, because it's a thick fluid, so you will need active thing. It doesn't come up like bullous retinal detachment of RD. So once that fluid is come out, you will see the retina settling down, and that actually makes rest of the dissection easier because now the retina is gone back.
A lot of times, ma'am, the break happens right around the arcade where the nodes are there. There is a lot of bleeding over there, a clot forms over there. Would you be aggressive in that first setting, or is there a chance that we may come back if required and leave the clot over there and try?
There was a time when we used to think of coming back, but these days with the pre-operative anti-VEGF and with the kind of the instrumentation we have, I don't think we have come back in a very long time. Because I remember long time ago, the bleeding would not get controlled. They will keep on bleeding, then you have to close and come back. But these days, that really does not happen. And the thing is, as soon as you see a bleeder, you have to, like I don't know, but I work very quickly, just go to 60, get my diathermy, bring it back to 30 when it is diathermized to see whether it is still oozing when you bring the pressure down and sort it out. Because that time the temptation is, since you are cutting, you finish the cutting and then come back to the bleeder. That sometimes creates a messy situation.
Yes.
Yeah, totally agree with you. That's why. But only thing is, to answer again one more addition. If you have a bleeder, unfortunately certain situation you just cannot control. Probably we still once in a while do, though routinely we do not. But if you have created break, probably it's not a good idea to come back again. Because once you have break, once you have a blood there, it can be good cocktail for PVR. Then difficult to handle later on. Only bleeding. You are ensuring that there is no other break. Probably these are the situation once in a while, though Dr. Vishali rightly mentioned, most of the time with anti-VEGF we do not have to deal with that, so you anticipate pre-operatively and add on anti-VEGF. But still once in a while it happened, things got delayed because of fitness, we could not have a surgery, and then you have rebound phenomena. And that situation, if you intraoperatively you feel is bleeding too much, not getting control, we want to stop before you create a break.
Right.
Thank
and sir,
you.
one last question to you. I have seen you work on pressures of 100 for diabetic vitrectomies and prefer not to do a diathermy. How much pressure would you say we can go to, and how much time can we stay there before we say, no, this needs a diathermy?
No, not really. 100 pressure, very, very rarely, because that was a patient probably you were that day. Yeah. It's a systolic pressure going on 210, and even if raising 60, 70, 80, 90, 100, just bleeding was not stopping. There are two reasons, high pressure and patient has a nephropathy also, so it was not clotting as well. Generally, we won't go around 50 or 60, maybe few seconds you wait, and incremental decrease, what Dr. Vishali rightly mentioned. You don't want to bring down immediately also. So go to every 5 millimeter of mercury every few seconds, wait, look at it. If not bleeding further, go down. Not bleeding further, go down. But the moment suppose you start oozing, you can probably again raise maybe 10 millimeter of Hg. Wait for a while, again go that way.
Right. Thank you. Thank you so
Thank
much.
you.